we'll just keep letting people pop on. So for those of you that don't know me, hi Erica, I'm Dr. Carrie Skony. I am a certified chiropractic sports physician, and I specialize in working with dancers, which is why I'm here with Dance Med. So thanks Dance Med for having me. It's been so fun to watch what everyone is doing online these last few weeks. So today we're going to talk about understanding common dance injuries, and I'm going to go through a few injuries that I think I get the most questions about when I'm in office, or what I see real commonly. And then people submitted a bunch of questions, and please feel free to jump in and add anything in the chat there, and we'll try to get to it. Keep in mind, I work primarily with pre-professional students. I do work with some professional dancers, but the majority of my work is in injury prevention and injury treatment for youth and adolescent athletes. The injury rates and types of injuries are a little bit different between the two populations, our still growing bodies and our mature professional athletes, dancers. Okay, so just keep that in mind. Okay, so what we're going to do is I'm going to try to screen share some pictures, just because I'm a visual learner and I talk with my hands, and I think it's helpful to see what we're talking about. So we're going to start at the hip, and we'll do hip, knee, foot, and ankle. And I think we only have like 30 to 40 minutes here. So again, pop on any questions that you might have. Okay, so first thing we're going to talk about that I get a lot of questions about, and I know there's a lot of content out there on this right now, and for some reason it's a really confusing topic, and that is hip disorders. So snapping hip and hip impingement, which are really common, especially in adolescent dancers. And they can happen for a couple of different reasons. So the first one that we're going to talk about that you've probably heard about is going to be like a snapping tendon. So your iliopsoas muscle is a deep hip flexor. The psoas portion starts up in your lumbar spine. It dives through your pelvic cavity and attaches there on the inside of your femur. And so when that muscle works, it flexes your leg, so it lifts your leg up. Well, the anatomy part of this is that the tendinous and muscular part of the muscle slide over the front of the hip joint, and that's part of its normal motion. Sometimes instead of sliding or gliding, it snaps. Okay, so this is one reason that a dancer might have a snapping hip syndrome. And if it snaps enough, it can get irritated. There's a little bursa there, which is a fluid-filled sac that can also become inflamed, and that turns into a iliopsoas bursitis, and that can be painful. But it's also really common for dancers to have this kind of snapping in their tendon and not have symptoms. So dancers often say, oh, I feel that, especially like when I lower my leg from batma, or if I'm laying on my back doing core work and stretching my legs out, I feel the snapping in my hip, particularly on the eccentric phase when they're lowering their leg, or maybe when they're doing a développé. Okay, so common to have that snap from the tendon. It doesn't necessarily always mean that it's pathological, that it's an injury, okay? There's usually some dysfunction going on in there, and from our perspective as dance medicine professionals and injury prevention standpoint, we would like to try to figure out why it's doing that and if there's anything we can do to control it. So one theory out there is that the iliopsoas muscle is tight, and when it's tight, instead of gliding, it snaps across the front of the hip. I don't actually find that to be that common in the dancer population, and I usually find the opposite, that they're very flexible in that muscle. And along with that hyperflexibility often comes some weakness. And so it could be that that muscle is stressed for other reasons and it needs strength, okay? One other reason that it may be more prominent to snap across the front of the hip is if there's some dysfunctional movement pattern in the hip joint itself. Primarily, what can happen sometimes is we start to get an anterior shift of the femoral head. Let's see if you can see. I can't see it's my ceiling. So this is the hip joint, okay? Here is where the femoral head sits in the acetabulum. That's the hip joint. And so from a functional standpoint, sometimes what happens is in a hip that's really mobile, this femoral head can actually shift forward a little bit. I'm exaggerating, but it shifts forward a little bit and starts to put pressure more anteriorly into the front of the hip. And that can be a reason for some dancers that snapping becomes more prominent. Another underlying dysfunction that can lead to the psoas being overactive or becoming irritated in that area would be weak, deep core muscles. So pelvic floor muscles, transverse abdominis, even diaphragm and multifidi muscle in the back. So there's these deep core muscles that really need to try to stabilize through the spine. And if they are not working appropriately for a dancer, the psoas can take over and can alter its mechanics a bit. So that's snapping, one version of snapping hip syndrome that we see. And what I recommend is if a dancer presents with it and says, oh yeah, that always happens, and I say, does it ever hurt? And they say no. We just start to gradually work on it and try to identify where the weak links are and see if we can prevent it from turning into something worse by identifying the other areas I already talked about. If it's painful, then it's become not only a dysfunctional issue, it's turned into a structural issue. And then we have other things to deal with, like inflammation, either in the bursa or the tendon. And so then the treatment becomes a little bit more focused on eliminating symptoms and then rebuilding the tissues through there. Okay. By the way, we're not going to do exercises today because there's a lot of that going on. There's so many awesome people that are doing exercises. Today, we're really going to focus on like the what and the why for injuries. So what is happening when this is going on and why is it happening? And the way I describe that to my patients is structure and function. So structure is what's actually happening to the structure and how has it been damaged, and function is why did it happen in the first place. And so we can treat structure sometimes. Surgery treats structure, boots treat structure, rest treats structure, but we really need to treat function, and that's why did it happen. And so that if that's the missing link in your injuries, it's really important to get with a therapist who understands, really wants to get to the bottom of this and why is it happening, and ask a lot of questions that way, because that's the key to success for some of these long-term injuries, especially in our dancers. Okay, so that's anterior snapping hip, or sometimes what we call internal snapping hip. There's another way that you can get snapping in the hip, and that's through the labrum. And many of you there's hip flexor again. Many of you may be familiar with the labrum. The labrum is a ring-like cartilage around the rim of the acetabulum in the pelvis, and it is where the femoral head sucks into the pelvis. So if we look back on our pelvis here, okay, here's the femoral head. This is what we call the acetabulum, where this sits, and it suctions in there. So there's this ring of cartilage all the way around here that helps hold the femoral head in place. It still allows a lot of movement, but it creates some pressure and some stability there. Okay. Now, what can happen is you can get a tear in the labrum. This is really common in dancers. Some dancers know when they tear their labrum, and some dancers have no idea when it happened, or it happened gradually over time. And that's okay. You can have a successful career with labral tears. The key is really in learning how to manage it. And some people do exhaust all of their options in conservative management and do end up having to get them repaired, but we often try to avoid that as much as possible. That's because this is a structural problem, the tear, that comes from a very detailed functional background. So if we can treat the functional part of it, and we can identify why did this happen, what are the stressors on the labrum, and we take the stressors off the labrum or modify how this dancer is working through the hip, we can often eliminate a lot of the symptoms in the hip. Okay, so the point is that when the labrum gets a little tear in it, like you see in these pictures here, you lose part of the suction of the hip. It's just not as tight of a bind through there, and the hip can start to move a little bit more, and we call that some micro instability in the hip. Again, very common in dancers, especially dancers who are flexible or have extreme ranges of motion. It's okay to have that. It's how we deal with it that's important. So when there's micro instability in the hip, this may move around a little bit more, and what can happen is you can actually start to hear some noise in that joint. And so we call it intra-articular, which just means inside the joint. Inside the joint, you're getting a little bit of it could be like a little bit of vacuum phenomenon where there's some air exchange in the joint. You could actually, in some cases, be catching part of that labrum and feel like a pinch, and then it has to pop to unpinch, is what my dancers say. So that's a labral tear in the hip, and like I said, we work on trying to stabilize the hip joint and really work on all the intricacies of the muscles around the hip so that the hip moves more efficiently while not pressing into and damaging the labrum. That's a labral tear. So, this is one reason why I ask dancers not to forcefully pop their hips repetitively. It gets a little addicting, but if it feels like, oh, it has to pop. And that may be true for sometimes. You may get stuck in your hip sometimes if you have one of these things going on. And in some cases, that may be an answer for you to have to be able to move that hip again. We try not to encourage that. We certainly don't like to encourage it repetitively or with significant force. So, because it can reinforce the patterns that are already there. And we want to try to eliminate that as much as possible. Okay, so that's hip labral tears. We can also talk real briefly that sometimes also gets lumped into this category, and that is going to be, can you see that picture? We'll do this picture. Femoral acetabular impingement, or what we call FAI. So impingement syndrome is in the hip is when you take your hip to a certain range and you feel kind of a hard stop or a pinch. That's FAI, if you've heard that before. A couple different ways that this can happen. One, sometimes we use the term FAI to refer to pinching on the labrum. If you repetitively kind of glide up and lean into that labrum when you're lifting your leg, especially if you hike through the hip and you have repetitive stress through there, you can start to pinch on the labrum, and that will reproduce some symptoms that are like FAI, hip impingement. The other thing that happens is you can start to develop all these extra little bony prominences around your hip, and they have medical terms, and we call them pincer or cam type impingements. Sometimes you have both, usually it's one or the other. And so what happens when there's a lot of stress on the bone in the hip, let's say, can you see this? Let me get rid of this for a second. Hold on. Can you see this? Okay. Here's my hip. So if I repetitively take this hip and move it up, 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 and these two surfaces rub on each other over long periods of time, bone responds to stress by laying down more bone. It's called Wolff's Law, and you can start to develop some extra bony formation through there. And so over a lot of repetition and time, suddenly you may lose some of that range of motion in that position, and that's called a bony impingement of femoral acetabular impingement. Once that bone formation is there, there's not a lot we can do to get rid of it. Surgically, it can be shaved down, and my preference is that we try to manage that conservatively as best as possible, and not go in to shave that down if we can at all help it. So we can do things like, if we catch it early, that's really important. So pay attention to those symptoms if you start to develop them. 2, so we can change your patterns of movement so we don't keep aggravating that same area and making it worse. And 3, learning how to properly modify. I see this in dancers who they can't take their leg all the way up in flexion here. They get stuck in pinching and they work and work and work just thinking, I gotta get it. But they're getting hard impingement through there. And if they take their leg 5 degrees into abduction, suddenly they have 10 to 15 degrees more of flexion, and they have to learn to modify that way to protect their hip joint. Okay, so that's called FAI impingement through there. All right, let's keep going here. We're gonna do D, and then we'll take questions. Okay. Or you can pop your questions in now if it's something that's relating to the hip. We're going to go into to the knee. Again, we're talking about structure and function here for those of you that are just joining. We're not going to go over exercises so much today, but we're going to be talking about what are the injuries and why do they happen, and that's the important part of healing from them. So the next thing that I see real commonly is patellofemoral pain in the knee, sometimes known as runner's knee in the outside world. I call it dancer's knee because it's really common in 13-year-old dancers. But essentially what happens through here, let's see if I can find a better picture. Hold on, guys. That might be the best one I have. Okay, so essentially what happens through here is the kneecap, I don't have a knee with me, sorry. The kneecap sits in a groove and kind of like a train on its track. So I go like this. Okay, imagine you're looking at the knee kind of like straight on if it's bent, and the kneecap sits in a track like this. And those surfaces are lined with cartilage. and they're supposed to lubricate and allow some glide through there. And when those surfaces get irritated, they become painful. So a reason that those surfaces may get irritated is if the patella is not sitting in its track correctly. And so if the patella gets pulled off to the side a little bit, and as you bend and straighten your knee, it starts rubbing, that starts causing friction. It doesn't usually cause pain right away. This could take months or sometimes years for some people for that cartilage to really start to break down a little bit and get inflamed. The pain that it feels like an achy pain around the kneecap. Some people feel it in different places. Sometimes they say at first it feels up here, some days it's down here, but it's generally around the kneecap. Some people say it's painful with stairs, with prolonged sitting, it's achy. A lot of times dancers initially can get through class fine. It's not till after class that they notice the pain, that it's achy. So that's patellofemoral pain. And I often find this misdiagnosed in our younger and adolescent dancers. And if they are going to their pediatrician or anyone who doesn't really understand the demands of dance, it's often misdiagnosed as either a patellar tendonitis or a quad strain, I've heard, or quadriceps tendonitis, because the pain is in that area. But really when we start to isolate the function of the knee and look at, well, the patellar tendon's really structurally and functionally okay, the quadriceps tendon's doing okay. But when I watch what the knee does when you bend and when you land, there's a lot of irritation under there. So that's patellofemoral pain. Okay, patellar tendonitis, I don't see that much. It's more common in our boy dancers than girls. And I see it more in like our kicking athletes, people who are kicking against the ball. But it does happen sometimes, but that is pain in a different area. It's in the tendon underneath the kneecap, usually with some really localized tenderness right when you press on it. It's pretty localized to that area, sometimes some swelling through there. Okay, well, the way that we essentially treat patellofemoral tracking and why it happens is, again, the kneecap is not sitting in place, and oftentimes the reason the kneecap is not sitting in place is because either the hips are weak or the feet are weak. Okay, the knee becomes the victim of weakness farther up or down the kinetic chain. Okay, the glutes control what happens to the knee when you land. And same with the foot. If the foot is collapsing in, you have weak arch and it's collapsing in, the knee takes the brunt of that work. Let me see if I can find a picture. Oops, hold on guys. Keep your questions coming through here. Oh shoot, I don't think I have a, wait, maybe I do. Hold on, I'm looking. How about this? Okay, so this is what happens. This would be a reason that the kneecap might start to get irritated. If when you're landing and on one leg or even on two legs, if the arch collapses and the hip is weak, the knee dives in like that, the kneecap gets pulled to the side and it starts to create irritation under the cartilage, and that will eventually turn into some pain. So you'd want to watch for some of that. Okay, I had a couple questions here. Can a torn labrum or hip impingement cause tight hips? Yes, tightness in the sense, we use the word tightness, like it probably feels tight, probably because it can limit your, what range you feel like you have. So if you feel like, oh, I can't lift my leg as much as I used to, that could happen because of the tear. And same with the impingement through there. So, and you may also just feel like a deep achy in the hip that feels tight. Tight is not a great definition of a word, but tight. I gotta plug in my phone. Hold on, guys. Okay, so what else do I have? I have the os trigonum bone. Yeah, we're gonna get to that. Let's do that next. Let me see if I can plug this in. Okay. Hold on. Okay, I think we're good. Os trigonum. Pinching in the back of the ankle. We're gonna do that next. Hi, Josephine. Okay, great. So let's keep going. Let's go to the knee. Oh, we didn't talk about meniscus. Meniscus tears are fairly common even in our young athletes. And they often do have to do still with hip strength and foot strength. And it's really how you land and what your foot relationship is to your knee. And so if you have torque in your knee, let's say if you're forcing turnout or the hip is weak and the knee dives in and the foot goes that way, there's twists through the knee and you can tear a meniscus that way. I do see that a lot. We'll come back to that if anyone has any specific questions. But let's go to the foot because, over 50% of injuries are really at the foot here. So let's look at this os trigonum. Can you see that? I don't know. My picture's in the way, but I can't tell. Okay, so if you look right at the back of the ankle, this is the dancer in releve through here, and if you look here, this is the talus bone. It's in the back of the ankle, and it has these little bony prominences on it. And for some people, those prominences are large, and for some people, they are not. And for some people, they stay attached, and for some people, they are just an extra little bone that doesn't attach to the talus. If there's an extra bone there, sometimes it can actually get like fractured or fragmented off, or sometimes you're just born with it. It's called an os trigonum, which is just a extra little bone. And you can see it on this x-ray. I can't point to it, but I keep trying. It's right at the base of the ankle where the heel comes up, and this should be going straight up, and it's right there. And so what happens with an os trigonum, you can have one and never know it. In fact, a lot of the normal population may have them and they don't know it because they don't spend exceedingly amounts of times in plantar flexion like we do as dancers. But repetitive work on point or in releve can create compression on that bone, and you can get some impingement symptoms. It usually feels like pain right in the back of the ankle. Could be slightly on the inside of the Achilles or slightly on the outside. I've seen both. Sometimes it's misdiagnosed as Achilles tendonitis. It usually only hurts when you point your foot all the way or when you're all the way up in releve. Some dancers only feel it when they're on point, not in releve, so they have to be fully loaded on it. So it can come in a variety of flavors that way. What we try to do is we try to minimize the contact on the os trigonum. So for dancers who have really hyper flexible feet and are really sinking into the back of that foot, we work on strength and control through that joint. Sometimes that talus joint, the front part of it, so it's the whole block of that bone, is hypermobile and it moves a lot. And so we can give a dancer exercises to help that bone glide better, so that when she goes up onto point, or he goes up into releve, that bone doesn't slide forward, causing more of an impingement. I have my foot that doesn't move today, and I'm so disappointed about that. Okay, so that's os trigonum. In some cases, we do have a surgical excision of the os, and that is a fairly easy procedure to have and recover from if it's not complicated by anything else. There's still a good amount of recovery from that, but we try as best we can to control the function around the foot, and in the end, if there is still some pressure through there, sometimes that little tiny fragment has to come out. Os trigonum. Okay, the other thing that can happen in the back of the ankle that can be posterior impingement is that would be of the FHL tendon. I saved all these pictures because I'm a visual person. Hold on. Okay, the FHL tendon is flexor hallucis longus, and this is a pretty long muscle. It goes through kind of the outside part of your calf, and then it dives underneath the calf and Achilles, and then it wraps around, this is the inside of the foot, comes down and it wraps around the inside of the foot and goes all the way down, all the way down to the big toe. Through there, okay? It's a long tendon, and the area that it gets most injured is right at the curve of the ankle, through here and right up in the back. This is a pretty small space. If I were to pull up an anatomy picture with maybe I do, hold on. I'm so prepared. This is a pretty small space, and there's a lot of tendons and vasculature and nerves that go through this area, and so it can get pretty tight in there. If we get any kind of little bit of swelling back in there, we can start to get some pinching on that FHL tendon. One of the reasons that FHL tendon, so that's the what, the tendon gets injured, and we want to know the why. One of the reasons the tendon gets injured is from overuse. And so flexor hallucis longus tendon is responsible for curling the big toe. Okay, it attaches at the end of the big toe, and so when it is active, it curls through the toe this way. So our dancers who are really grippy with their toes, or when they point their foot, they curl their toes under, this tendon is susceptible to some overuse injury through there. So it's a gradual process of where the tendon starts to get overloaded over time. It starts to build up some inflammation, and then it gets there's not enough space in the back of the ankle for it to move and glide. And especially because this tendon in particular slides through what we call a sheath. And a sheath is just kind of this slippery like cave that it slides through, and or tunnel would be the right word, tunnel that it slides through. And so you can get swelling in the tendon, and then it kind of gets stuck sometimes, or you hear it pop as it goes through the tunnel. One way you can check this if you have pain in that area, or sometimes you can have the popping before you even get pain, is put your finger on the inside of your ankle through here. Demi point your foot, and then point or curl your toes and see if you feel a pop that goes with that. If you do, that's your FHL tendon sliding through its tendon sheath, and it means it's one of those structures is probably pretty irritated. Now, it may not be to the point where you have symptoms yet, but it's a dysfunction that may eventually lead to a structural problem. Okay, this is important. So that's FHL tendon. I don't routinely recommend towel curling exercises just because I think this muscle has a propensity to get overused. Instead, we do toe doming. So instead of curling under, we dome, which actually is lifting, again, my inflexible foot. It doesn't move. It lifts the ball of the foot and keeps the toes long. So you're not curling under, you're pressing the pads of the toe down without curling under. And so those are kind of our short flexor muscles in the arch of the foot. And those muscles, we want to be very balanced with our long flexors, the flexor hallucis longus. When those are balanced, we can have better control of the toes and less likely that FHL is going to turn into an overuse injury. The other reason that sometimes this gets injured is because dancers who use their big toe a lot for balance. If you shift all of your weight onto that great toe, onto your first toe, and you really rely on your big toe to be all of your balance when you're in releve or you're turning, you are constantly using that muscle, and it's a pretty small muscle. And so we just want to make sure in that case that your weight distribution is correct for you, and also that your calf muscles are really strong. Okay, sometimes when the calf fatigues, this muscle will take over and you're just literally hanging on for dear life in your releve by your big toe, and that's a lot. So calf strengthening would be a good way to compensate for some of this overuse in the flexor hallucis longus. Okay, any questions on that? Jump on in. I have some other questions from yesterday. Did that answer the questions about the osteogotum? Whoever asked that, I'm sorry, I don't remember who asked. Okay, let's talk about hallux valgus. Hallux valgus is this picture on the left when your big toe starts to drift inward. Okay, that's the what. The why that happens could be a number of things, but the number one thing that I think is a weakness in the abductor hallucis muscle. There's an anatomy quiz later, guys, so make sure you're paying attention. I'm kidding. There's not. Where is I? You guys, I saved these pictures and now I can't find them because I'm horrible at technology. Okay, well, whatever. Okay, anyway, on the left, the great toe is starting to drift inward. That's called hallux valgus. And so it happens because there's a weakness in a muscle in the foot. So here's the bottom of your foot. There's a muscle right here that comes up and attaches to your big toe, and its purpose when it contracts is to pull your big toe this way. Okay? When this muscle is weak or lengthened, this muscle has no counterbalance to it, and it naturally just starts to drift in like this. Okay? Now, there's a lot of underlying reasons why that muscle might be weak. It's usually overall some intrinsic muscle weakness in the foot. So all of the little arch muscles that control our toes and lift all the different arches of our foot can be really weak. And then we start to lose some control of those toes, okay? So, there's tons of exercises out there for foot strengthening. Check out, is Jennifer Milner on here? Check out, she has hashtag Foot Care Friday. She's done a bunch of intrinsic foot strengthening. So check that out. She has some great exercises there that we use. But we work on strengthening through like toe spreading and getting that muscle nice and strong. Okay, so you can have hallux valgus, which is the shifting part of the structure, without necessarily having a bunion. A bunion is a second step in the process, okay? So the first what is drifting of the toe, and the why is a weakness in the muscles in the feet, okay? The next step, if that progresses and you continue to put weight through that first joint in your toe, here, that big toe, if this is loaded excessively over time, it will respond to that stress. This is a chronic injury. So this toe is drifted in. More stress to a bone means more bone growth. The capsule in that area starts to swell. We start to get extra bony formation, and that's what you see is a bunion. So you can see in this picture, both of these feet have prominent bunions. In our young dancers, if we start to see a drift to hallux valgus without pain in the joint and without any real sign of bony formation or bunion, we get on that because we can fix the function of that. Once there's a significant bunion and bone formation, it is challenging to correct for that, and a lot of times we are just managing symptoms of the bunion and trying to reteach dancers who have a long history of maybe not using those muscles correctly, and that's hard. Okay, bunions can be red, they can be swollen, they can be painful, they can start to limit your range of motion in that big toe, so it might be hard to get all the way up into releve if there's enough bony formation there, and they can just ache in general, so we like to try to prevent that. Okay, good. How are we doing on time, guys? I think, Jasley, are you on? I think I have 30 minutes. I'm at 30 minutes. I'm going to answer questions. Let's see what we can do here. Hold on. Okay, I'm going to slide back up here, see if I missed anything. Keep the questions coming. If you have symptoms that you've experienced before and you don't understand why, let's talk about them. So yeah, addressing pinching in the back of the ankle on point. Oh, and the ankle feeling stuck in plie. Rebecca, I didn't get the second part of your question here, but pinching in the back of the ankle is that posterior impingement. It's either the os trigonum or it's some soft tissue pinching back there. I've even seen sometimes that you can have like part of the joint capsule, like you can have some soft tissue like capsular things back there pinching for really hypermobile feet. So when you go to get, again, we're not talking a lot about treatment right now, but when you go to get treatment, you need to keep that in mind. You know, what can I change? What can my therapist and I change to eliminate that pinching through there? Pain in the front of the ankle when you go down into plie, that's called anterior impingement. And an anterior impingement, here's the front of the ankle. You can actually, some people have a little bit extra bone through here or can develop it over time. If this bone moved, it would go like this, and you would see that these two surfaces approximate each other, and you can get the same kind of pinching here that feels stuck. The thing with pinching that we want to be aware of is not to press through it. You don't want to push into it. More is not always better in this case, because you can actually aggravate it. You can make it more inflamed. You can, create more bone stress through there, so you don't want that. What would pinching upon extreme flexion of the knee be? Pinching is deep of the patella. Oh, any type of pinching, locking, getting stuck in the knee could very easily be meniscus, a meniscus tear through there. So that would be my first place to rule out. Or to look at. When you tear a meniscus, some people lose their ability to flex all the way, and some people lose their ability to extend all of the way. It depends on where the tear is and what the mechanism is and what you're doing. But if the pinching, especially if it limits you from doing your daily activities in dance, then I would definitely get that checked out to see. You can get like a sharp pain under the kneecap. That doesn't sound like what you're talking about, but in full flexion, sometimes you can just feel like, significant compression in that area. I'd start by ruling out meniscus. Whenever I bounce my butterflies, I feel and hear my hip cracking. What could that mean? Yeah, that could mean one of the two things. If you were here earlier, we talked about either snapping iliopsoas tendon over the front part of the hip, or a little bit of interarticular extra joint motion in the hip. I would recommend not bouncing through butterflies. Bouncing becomes a little bit of a ballistic stretch, and I would recommend a prolonged stretch or even a dynamic stretch where you're moving through movement. If you're trying to open up through the hip joint there, I recommend like Carr's movements on the hip, controlled articular rotations. I have a video of that on my page if you look for that, or let me know. But the idea of trying to retrain and control the range of motion in the hip either way, so that we're eliminating or reducing the amount of stress on the iliopsoas tendon as it slides back and forth over the front of the hip joint, or trying to gain some stability and control in the hip as it moves. How do you treat the femoral kneecap problem? That's hip strengthening and foot strengthening, almost always. It's a whole kinetic chain problem. We treat the knee for symptoms, so sometimes we have to stretch the quad, and sometimes we have to stimulate the medial quad muscle because that's not working. But if that's not the only treatment, I feel sometimes in PT, dancers are only getting like quad exercises, and that will not fix patellofemoral pain in dancers most of the time. Okay, their hips need to be stronger. Usually we look at their turnout, because there's some faulty turnout there, and they have some torque in their knee. So it's usually above and below the knee that we need to address. The glutes are often weak. Yeah. Let's see here. Also, whenever I straighten my knee, it cracks as well. Yeah, that can be, it can be a couple different things. Depends if you're hyperextended or not through there, but any kind of repetitive like cracking in the knee could be some instability in the knee, particularly like in the cartilage and the meniscus. I recommend that if you haven't been evaluated by someone who understands dance, that you do that first. And there's lots of ways that we can reduce the irritation to that, eliminate that aggravating position, and create strength around the quads and the hamstrings, even in the calf muscles, to try to reduce how much that happens. But it sounds like it could be a little meniscus tear in there that you catch when you're moving through that range of motion. Differences in presenting symptoms between labral tears and FAI. Yeah. To the patient, they may not feel anything different. To us, we can often tell the difference. When I test a hip, I can feel a bony end feel, so I can go here and reproduce it, or you can't see it. I'm doing this like you know what I'm doing. I'm sorry. I work with my hands. So here's a hip, okay? Here's a hip. And so I can, when I come up like this, I can feel when I'm testing the patient that that's a bony impingement. And I can put them in different positions and try to figure out where that is and get a good idea of what that might look like. And they will say, that's it. That's where I feel stuck. I can't go any farther. That tends to be a FAI. The tricky part is the labrum's right there too. So sometimes people who have FAIs have torn the labrum at the same spot. Labral tears, dancers often complain of popping in the hip, or getting stuck, like not at their end range, not like I can't move that leg, but more like I was plieing and my hip got stuck and I like couldn't move it. So that's can happen with labral tears that you would not see necessarily if it was just a bony impingement in the hip. How to address pain when keeping hips up in second position plie. How to address pain when keeping hips up in second position plie and grand plie. I'm not sure I understand your question, but remember, dancers' hips are going to be, if we're talking specifically about grand plie, dancers have different shaped hips. This is really important to know in our classes from an anatomy perspective, is some dancers have really shallow hips and they can move their hips in lots of positions, and some dancers have very deep sockets and they cannot. Some hips face more forward and some hips face more backwards. And sometimes one dancer may have different shaped hips in their same body. So not everyone can do every position and sometimes require some modification. So if a dancer is going down, let's say into a second grand plie, and they're getting pain or pinching through there, one, you want to check their technique and alignment and make sure that that's correct first. Are they engaging their deep rotators in the hip? Are they not tilting through the pelvis? They have a good core activation and they're really lifted through there. If that's all true and they're still getting some pinching or pain through there, it may be part of their anatomy and they may not be able to go as far down into that position. What if you feel a pop or a grind in front of the ankle when going to full releve? Yeah, do you mean on the way up? So yes, it could be either on the way up or the way down. My experience is that there's some, commonly, if we're talking about a dancer here, there's some instability in this region. And so that joint can shift just ever so slightly. It's mild, but relatively speaking, those little differences can matter. And so you could get popping when you go up into that position or down through there. So that's one option. Two, occasionally we can get little chondral defects inside the ankle through here. Usually presents more of a pain than a popping, but I have seen some that have some popping right in the front of the ankle joint through there, and it's a little damage, injury to the cartilage on that bone. Maybe from a previous ankle sprain or impact injury through there. Sometimes that is part of it. If there's grinding, it may mean that you have two surfaces that are rubbing up against each other, like the cartilage is irritated through there. So either it's a poor alignment issue or a chronic issue where there's been a lot of grinding over time, and that may start to wear down a little bit. Definitely get it checked out by someone who understands what you're doing in dance. Josephine, where were you when I was 13? Let's see here. Is it necessary to have surgery for that extra bone in the back of the ankle? Not really. It depends on your symptoms. I have dancers who have it, who have been able to modify and recover and move on. I have dancers who have done everything right and rehabbed it, and it still bothers them, and they want to go on to a professional career, and it's just easier to take it out. It's easier to take it out before it turns into something else. So in those cases, if we can catch it before it also turns into a soft tissue impingement and an FHL problem, and we start to get some other structural changes, then it's relatively easy to recover from that. But I say, at all costs, fix the function first, because if the dysfunction is still there, you can get. This is true for all dance injuries. If the dysfunction is there, if the why is still happening, you can fix the what, and the what will come back in a large majority of cases. So do the prehab, do the work before surgery. For most cases, I know some surgeries require immediate attention, so this has a little asterisk on it. But for these chronic problems, if we can fix the dysfunction first, then if you end up needing surgery, fine. But you've already fixed a lot of the dysfunction that led to the problem in the first place. You can come back to dance easier and with less risk of return of injury. Dylan, is there any orthos to diagnose it, or is it only by x-ray? X-ray primarily to get a confirmation, although not all of them show up on x-ray, so sometimes we need CT or MRI to look at. I think you're talking about the os. Is that right, Dylan? I think you're talking about the os bone. Anyway, I do, a forced plantar flexion orthopedic test. And so the foot is relaxed. So I know it's not Achilles. They're not engaging any part of the musculoskeletal system. And I just do forced plantar flexion with the heel into end range. And if that reproduces their pain, I know they're getting some kind of impingement. So it's either just that posterior talus that is attached, or it's an os trigonum bone. How common is it to be injured at the big toe? Yeah, I think that's fairly common. I see capsular injuries at the big toe, so I don't know, you could clarify maybe what injury you're talking about. dancers who like walk on their knuckle and do that or stretch through there, they can get capsular problems in this joint. That can turn into a capsulitis that gets inflamed, and really irritated through there. Dancers who pop their toes over and over again can get swelling in that joint, and that can be very similar. It can calm down, but we need to stop the offending activity, loading through it, or popping, every 5 minutes in class. Big toe injury, really common in dancers is the hallux valgus or the bunion, like we already talked about. A lot of that has that bunion, another reason for the bunion, the Y, is rolling in on the foot. So when dancers have weak arch support through here and they overpronate and roll into that foot, a lot of weight goes into that toe. And so there's a lot of stress in that joint. Forced turnout, if you were in my presentation a couple days ago, we were talking about forced turnout. That would be another reason. Forcing through here, we lose control of the arch. The foot rolls in, and now you have this foot that's cranked backwards, and you're supporting yourself with that joint, and that can get irritated. Let's see here. I'll take that off, sorry. I see. How common is the FHL? How common is it for the FHL to be injured at the big toe? Not that common. What can get injured there is the sesamoid bones. The sesamoid bones sit in the FHL tendon, and that is more likely to get injured. I'm certain I have a picture of that. Okay, if you can see this, there's two little floating bones under the big toe. They're called the sesamoid bones. They just float in that tendon through there. They're meant to help distribute forces and guide the tendon, and they're cute little bones, but they can get irritated, and it's called a sesamoiditis. And the reason that it gets irritated is too much pressure on the bone, particularly for our dancers, again, that roll into that big toe and use that a lot. If our dancer overpronates and they start to get a rotation in the metatarsal this way, the sesamoid bones shift. So they're supposed to sit like right under here, and if this rolls, the sesamoid bones shift, and then they're more susceptible to some impact. Dancers who don't control their load very well when they jump, either going up or coming down for their jumps, are more susceptible to that. And so if you're feeling pain under your big toe, it could be a sesamoiditis, and we treat that by treating the functional part of it. So that's lifting the arches with proper support in the intrinsic muscles, trying to derotate the metatarsal with muscles, and also teaching the dancer how to do that with tape for the meantime to get the sesamoids to sit correctly. Rest, we use a dancer's pad under the metatarsal, which is essentially like a cutout pad, so that they put most of the pressure like on the ball of their foot and not on the sesamoid bone. And then we also look at like how they're doing releve and where they're shifting that weight if there's some kind of overuse through there. Okay, you guys have great questions. Foot doming, yes. Do you have any exercises for how to get your arches more flexible without stretching your feet? Because when I stretch my feet, it aggravates my ankle. Yeah, huge problem with foot stretchers. Be really careful about when you are recommending or when you're using a foot stretcher. Not every foot needs a foot stretcher. Foot stretchers with prolonged use can stretch ligaments, and ligaments are protective, and we have dozens of them in our feet, and you may not know exactly what you're stretching when you're doing that. So we need ligaments to keep our foot nice and stable. And yes, so if you have pain, which happens when people put their foot in a foot stretcher and it forces the heel and it really stretches through the arch, that's not an exercise for you. That's a stretch. But exercise to help strengthen your foot, you need all those foot intrinsic exercises. So we do all kinds of toe movements, spreading and toe swapping and toe doming and short foot series. Again, look for those amongst the dance medicine community because there are lots of them outside the scope of what we're doing today. But yes, definitely figure out how to do those, and don't use a foot stretcher if it is hurting you. Okay, thanks. I can keep going. Josephine says, thanks, dear. Okay, great. If you sprained an ankle and it is constantly swollen and loss of range, is it possible to get it back? Yes, it is possible. There could be a lot of variables or ifs there, but constantly swollen means that swelling is the body's response to try to recover from something. When you sprain your ankle, let me see. was gonna try. You guys, my pictures have failed me. I know it's in here somewhere. Okay, we've all seen this. When you sprain your ankle significantly on the outside of the ankle, you have bruising and swelling. That usually indicates that there's a significant amount of injury on the lateral ligaments of the foot. There's 3 lateral ligaments in the foot, and you can injure any of them. Here's a picture. So there's the one in the front, one straight down, and one in the back. And when you roll your ankle to the side, you can damage those ligaments. If you don't have a lot of swelling or bruising, you probably haven't had significant damage through there, but you still would require some rehab to regain proper strength in the ankle. But if you've had swelling and bruising, there's likely you've had either some micro tearing or some complete tearing in those ligaments. What I see when I see persisting swelling with activity or even like daily activities, walking, if that swelling is not going away, it means there's not healing happening, which often means that the injury is probably more significant than you think it is. So MRI would check to see if there are torn ligaments through there. You may need to come off of it for a little bit to give it a chance to calm down. We definitely want to use compression to try to get some of that swelling out of there in the first place. Sometimes we can have, like I said, little injuries on the inside of the ankle joint through here that cause persisting swelling. An osteochondral defect could do that. But swelling means something's still going on. It's not normal for it to keep swelling after an acute injury. I use, after an acute injury, I use a horseshoe type pad. I always recommend that to dancers to try to get that initial swelling out of there. It will give you a lot of more comfort to get some of that swelling out and will help you get your range of motion back faster. And you can put that under like your wrap or your brace. But yeah, if you have swelling through there that's persisting and you've lost range of motion, I mean, some of the loss of range of motion may just be because there's swelling in there. That's possible. Otherwise, you could have a little fragment that's limiting your range of motion, a little bony fragment. You could have, if those ligaments are torn, you could just have too much pain to get into some of those positions. Yeah. Abductor hallucis muscle is the muscle that you want to use to strengthen the big toe, and that's called toe spreading, that way. And Foot Care Friday, hashtag Foot Care Friday under Jennifer Milner. She's demonstrated a lot of them beautifully. Check hers out or ask me, I'll send you videos. And snapping hip is a pain related to, where'd it go? Is pain related to the snapping or does it develop later with bursitis? Yes, it could be either. The tendon itself can get really irritated or the bursa underneath can swell. It could be either, sometimes both. And sometimes it happens in conjunction with like an interarticular labral thing too. So you could have both. You can have ticks and fleas, as we say. You could have some instability here that's over time has created some stress on the iliopsoas tendon as it crosses the front of the hip. That goes on long enough. The bursa is trying to keep up and like provide a nice fluid, lubricated surface for it to slide over. And then the bursa kind of says, I'm out, and it gets all swollen. And so then everything hurts. Do you have any exercises or how to get your arches more flexible? Oh, we did that one, sorry. I pulled my quadratus femoris muscle and can't go to the doctor because of quarantine. Shoot. Quadratus femoris is a deep rotator in the back of the hip. I'm curious how you pulled that. That's kind of an unusual pull. Here's what you should know about the hip. I'll kind of come back to that in a second. Here's what you should know about the hip. Hip pain is not always hip pain. Hip pain can refer a lot of different places. I had someone yesterday ask me about adductors, which I'll try to get to. Jasly or Josephine, if you can tell me, if you want me to get off, then tell me. So hip pain, like a hip labral tear or impingement on a labrum can refer, and you may never know it's a hip thing. It can refer into the proximal adductors, like in your groin, and it can also refer deep into the back of your hip, almost like at the base of your buttocks. I see that, and people come in and say, oh, it's my adductors, oh, I keep pulling it, or it's always tight and it just always hurts, but their adductors end up being fine, and it's their hip that's referring pain there. So that would be my first question, because I don't really have a great mechanism for how you pulled your quadratus femoris, unless you were in like you fell, you're in a really deep stretch, overuse, I'm not sure, but it might be a referred pain. Message me later if you want to talk about that. I have pain under my kneecap when I extend my leg full, like in a frappe. Any insights? I've been diagnosed with a loose ACL but no trauma. and had a quad tear in the vastus intermedius 2 years ago. Okay, so if you had a tear, if you have a known documented tear in the quad, you may not have fully gotten back to full function in the quad, because it can take a long time to retrain that muscle how to work appropriately. So that might be my first guess. One, it could be, you may not have regained full strength, and two, you may have some faulty firing patterns in the quad because of that injury. So that could be it, or even some scar tissue through there, which may be inhibiting how that muscle works. That's possible. Under your kneecap, when you extend your leg like that, though, it could either be, if you're hyperextending, if you have a hyperextended knee, you could be going into hyperextension and getting a pinch there. If it's not that, it could be a tracking disorder. If you were on earlier, we talked about that, about how the kneecap doesn't sit in its groove like this, and it starts rubbing, and so when you go to straighten the leg all the way, you may be starting to feel some of that irritation. That's a possibility. Meniscus may be a possibility if you're going to that full extension and you're getting a pain there. Yes to prehab. Woohoo! Hi friends, good to see you guys. Thanks for hopping on. Okay, I'm getting through these. And then I have a couple more. Oh, this automatically cuts me off at noon. Oh, I got 3 minutes. I can do this again if you guys have other questions. I hope that you had some information that was helpful for you. I know I had some other questions. One other question that came up a bunch was adductors in the hip. So adductors, remember this, are synergist to psoas, which is a deep hip flexor. If your adductors are chronically tight, your psoas or hip flexors are probably weak on the same side. Otherwise, your opposite side, your oblique muscles and your abdominals on the other side may be weak. So, and the adductor pain may be referring from the hip. So keep those things in mind. Message me if you want to talk more about that. I'm sorry I didn't get to all the questions that everyone had, but I hope this was informative for you, and I love chatting about understanding dance injuries, and I think it's so important as a dancer that you are just not understanding what it is. Inflammation is one thing and you can treat inflammation, but if you don't understand why the inflammation happened in the first place, you're gonna get nowhere as a dancer. You must have a really good understanding, and your doctors and therapists must have a really good understanding of why that happens. I am going to save this. It will be in Instagram stories on Dance Med for the next 24 hours, I believe, so you can watch it again. And shoot me a message if you feel like there are other things you want to talk about, or I could always hop on over to my Instagram story at some point and answer some more if you're just dying to know. I know it's hard sometimes when you have a lot of questions and don't know who to ask. And I love to talk about them. So thanks, guys. You guys are awesome. Stay safe and healthy, and thanks again, Dance Med, for having me. Make sure you're following them for their awesome lineups of professionals talking. Stay safe, stay healthy.